going to discuss about acoustic neuroma. It is also known as vestibular schwannoma or neurolemoma or eighth nerve tumor. 80% of cerebellopontine angle tumors consist of acoustic neuroma and 10% of all brain tumors consist of this. So it is a first when the tumor word comes, what we thought whether it is malignant or benign. So it is benign tumor. The cells will be spindle shaped with the nuclei will be rod shaped nuclei. They are arranged in the palisading pattern. These are in neurofibromatosis patients. The tumor is bilateral. Okay, origin and growth of tumor. Vestibular schwannoma. What do you understand by the word vestibular? Means vestibular division of the eighth nerve. Vestibulocochlear nerve is eighth nerve. So from cochlear division it is rarely arises, mainly vestibular division. So here vestibular division of eighth cranial nerve. Schwannoma means it is arising from the schwann cells and within the internal auditory canal. So it expands. On expansion it causes erosion of the internal auditory canal. Then the tumor will appear in the cerebellopontine angle. It grows, if it grows anterior, it has two chances whether to grow anterior superiorly or grow inferiorly. If it grows anterior superiorly, it involves the fifth cranial nerve. If inferiorly it grow means it involves 9th and 11th cranial nerves. Okay. So in later stages, it causes displacement of the brain stem and it makes a pressure on the cerebellum. So there will be raised ICT, intracranial tension. So extremely, it is very slow growing the tumor. So on taking history, patient will say he had these symptoms, means he had progressive symptoms from some 12 years, 10 years back, like that they will say, because it is slow growing. Classification will be small size. It may be like 1.5 centimeters, 1 to 1.5 centimeters at initial stages. Medium size 1.5 to 4 centimeters. Large size 4 centimeters. So clinical features. So you will see this diagram. You will understand how the tumor. So first is involving like only 8th and 7th nerve also. Later it is involving, it is somewhat big and a chance of extending to that of CPA. Then it is tumor, it is pressing on the fifth cranial nerve. So you can understand this is fifth cranial nerve. It has three divisions. One is ophthalmic and another one is maxillary and another one is mandibular. Later the tumor becomes very large. So it presses on the fifth cranial nerve, 9th, 10th and 11th, and it also involves the brainstem and the cerebellum. Okay. So that is the diagram. So based on the sizes, it will like impinge on the cerebellum or CPA, or it so only 7th or 8th may involve, or so if it is very large size, you will find the cerebellum symptoms, symptoms. Okay. So coming to clinical features, age and sex. So the patient will be coming to the OPD like aged 40 to 60 years. So and male is to female predisposition is equal. And then cochleovestibular symptoms are, the earliest symptoms will be when the tumor is still in the intracanaliculi. So as we see in the diagram also, the first one is first picture, it is intracanalicular. Okay. So if the tumor is intracanalicular, caused by pressure on the cochlear or vestibular nerve fibers, on the internal artery artery also some pressure will exert because of the tumor. So due to this, the earliest symptoms will develop. So like tinnitus, those symptoms will, sudden hearing loss, okay, vertigo, like those symptoms. Okay. The tumor is usually unilateral. It is progressive, and sensory neural hearing loss the patient complains of. It is associated with the tinnitus, buzzing sound in the ear. And history of, this is very important complaint, you should never ignore this. History of difficulty in understanding the speech. Some patients they will say we had sudden hearing loss, they will say, and history of imbalance, unsteadiness in walking, and vestibular symptoms. These are vestibular symptoms where true vertigo is very seldomly seen, because as growth is slow, our it is compensation will occur. Okay, so and our immunity like that compensation occurs, so we can't see the true vertigo in all cases, seldomly we will see that. So next, cranial nerve involvement. Fifth, cranial nerve, as we saw before, if the tumor has two chances, one is anterior superiorly it can grow, or inferiorly. If it grows anterior superiorly, then fifth nerve is the earliest nerve to be involved. Reduced corneal means trigeminal, no? So we will see the ophthalmic division. There is reduced corneal sensitivity, numbness, paresthesia of the face. So indication is tumor is 2.5 centimeters in the diameter. It is occupying the cerebellopontine angle. If the seventh cranial nerve is involved, sensory fibers of the early to involved, then motor, hyposthesia of the posterior meatal wall occur. This is known as Hirt-Zellweger sign. Loss of taste, we can tested by electrogustometry, and reduced lacrimation occur. We'll do this by shimmer test. Motor fibers affect late, delayed blink reflex occurs as an early manifestation. Okay. And if ninth and 10th cranial nerves are involved, so ninth nerve is glossopharyngeal and 10th is vagus. So they are mainly involved in the pharyngeal, laryngeal, palatal reflexes. So these palatal, pharyngeal, laryngeal palsy occurs. So patient will complain of dysphagia and hoarseness in the voice. As hoarseness because of laryngeal palsy, dysphagia because of palatal and pharyngeal palsy. Other cranial nerves, 11th, 12th, 3rd, 4th, 6th are affected when tumor is very large. So brainstem involvement, if brainstem is involved, brainstem consists of medulla, pons and midbrain, right? So you will find ataxia, weakness and numbness of the arms and legs with exaggerated tendon reflexes. When long motor and sensory tracts are involved, medulla has many tracts. If the tracts are involved, these are the patient complaints of. So inner aspect of lateral end of internal acoustic okay, internal artery canal with structures passing through the different areas. Here you see this Bill's bar is separating superior vestibular nerve from the cranial nerve 7. So here superior vestibular nerve which supplies to the utricle superior and lateral canals, and here you see inferior vestibular nerve, foramen singular for the posterior vestibular nerve to posterior canal. Here you see cochlea nerve. This is transverse crus which separates cranial nerve 7 from the cochlea nerve. So coming to if the cerebellum is involved, cerebellum when it will be involving. If the tumor is very large, it is greater than 4 centimeters, then you will see the cerebellar involvement. Okay. Some okay 4 to 7 centimeters like that. So so how you will know, you will come to know then there is cerebellum involvement. Cerebellum is important for the balance. So we'll ask the patient to touch the nose. So from finger to nose, the patient can't touch the nose exactly, and the finger will be like shivering. Okay, you will ask the patient for knee heel test. You ask him to touch the knee with the heel, and you see patient can't do that. And dysdiadochokinesia, the patient can't walk in a proper single straight line. He will deviate. Okay, ataxic gait you will see, inability to walk along the straight. Raised intracranial tension. What are the features? A patient will be complaining of headache, nausea, vomiting, double vision, papilloedema, blurring of the vision. So patient neurological examination we should do of cranial nerve, cerebellar function, brainstem signs of pyramidal tract and sensory tracts. You will observe this all. Okay, and fundus you will see blurring of disc margins and papilledema. Okay. So this we before only discussed. If the tumor is very small, it is intracanaliculaar. So only you will see regarding 8th nerve symptoms and some portion of 7th nerve symptoms. So if the tumor is somewhat big, it may extend to cerebellopontine angle. If the tumor is more than 2.5 centimeters, cranial nerve 9, 10, 11. Also maybe like if the tumor is very large, then cranial 9, 10, 11 along with the fifth is involved. If the tumor is 2.5, 1.5 to 2.5, then cranial nerve 5 is involved. Okay. Investigations and diagnosis. Audiological test. So first we should know difference between cochlear from a retrocochlear lesion. Acoustic neuroma is a retrocochlear lesion. Rarely cochlear will be involved. So we should differentiate. Pure tone audiogram is normal in normal hearing. Cochlear lesion, a sensory neural hearing loss you will appreciate. Retrocochlear lesion also you will appreciate SNHL. Speech discrimination score 90 to 100%. Here it is less than 90%, very poor in retrocochlear lesion. Rodonal phenomena is absent, cochlear lesion is also absent, whereas retrocochlear it is present. Recruitment is absent in normal, whereas present in both the cochlear and retrocochlear. CC score is 0 to 15% in normal, greater than 70 in cochlear, 0 to 20% in retrocochlear. Threshold tone decay test is 0 to 15 decibels in normal, less than 25 decibels in cochlear and greater than 25 decibels in retrocochlear. Striplin reflex is normal in both normal and cochlear, whereas absent in retrocochlear lesion. Stapedial reflex decay is normal and it is absent in retrocochlear. Okay, Bera if you do. There is normal interval between wave 1 and wave 1 and 5, whereas normal interval between wave 1 and 5 in both normal and cochlear, whereas wave 5 is delayed or absent in retrocochlear. So pure tone audiometry, you will see air and bone conduction shows SNHL, sensory neural hearing loss, by doing these all Weber's, Rennie's, Schwab's. You will find that this SNHL more marked in higher frequencies. Speech audiometry, poor speech discrimination disproportionate to pure tone hearing. Okay. Rollover phenomena, reduction of the discrimination score. Loudness increase beyond the particular limit. If loudness is increased, then there is a reduction in the discrimination score. So brainstem evoked response audiometry, this is BERA. It is useful in the diagnosis of retrocochlear lesions. In presence of 8th nerve tumor, delay of 0.2 meter second in wave 5 between 2 years is significant for BERA. So to appreciate the BERA. So vestibular test, caloric test, diminished or absent response in 96% of patient. When tumor is very small, caloric test is normal. Okay. Only in large tumors we can appreciate this caloric test, which is a vestibular test. Imaging studies, MRI with gadolinium contrast. It is superior to CT, gold standard for diagnosis of acoustic neuroma and other tumors of the cerebellopontine angle. More sensitive and specific, it is non-invasive, no radiation, so preferred. Intracanalular tumor, few mm, if it is few mm, it is easily diagnosed. Mainly for intracanalular tumors, you will use MRI. CT when MRI is not feasible. When MRI not feasible, if the claustrophobic patients, the patient will be very irritable to sound, then you can't do MRI. And cardiac pacemakers, if the patient had, then we can't. Cochlear implant is there, we can't do MRI. So CT is good to show any erosion of the temporal bone. Bones you can see better through CT, whereas MRI you can see soft tissues better. So plain X-rays, transorbital, stenverse, Townies and submento vertical. Okay. Vertical views you will do plain X-rays. Vertebral angiography helpful to differentiate acoustic neuroma from other tumors of cerebellopontine angle. CSF examination, proteins will be raised. Important tests are pure tone audiometry, speech discrimination score, rollover curve, evoked response audiometry, imaging studies. Then differentiate diagnosis, you should differentiate from acoustic neuroma from meningioma, epidermoid cyst, primary cholesteatoma, aragonoid cyst, schwannoma of other cranial nerves, aneurysm, glomus tumor, and some other metastases. Treatment will be surgery. You should remove the tumor surgically. So various approaches are middle cranial fossa approach, translabyrinthine approach, suboccipital retrosigmoid approach, combined translabyrinthine suboccipital approach. So radiotherapy is X knife or gamma knife surgery. So if the patient is not willing to undergo this surgery, so you can do this. So form of stereotactic radiotherapy, it is gamma knife therapy or X knife therapy. So radiation converged on the tumor, arrest of the growth of the tumor, so it reduces its size. X knife surgery, linear accelerated, that is gamma knife through a 0 to 60 core source, okay, 460 source. So cyber knife without skull trim for stereotactic localization, and it is more accurate. It uses real-time image guidance technology through computer controlled robotics. Okay. If surgery is contraindicated, you will do radiotherapy. So X knife or gamma knife, so that you can reduce the size and arrest the growth of the tumor. That's it for today. So acoustic neuroma is very important. So first, it may involve only intracanalicula, means only 8th nerve may be involved. If it grows anteriorly, then 5th nerve will involve, and if it goes inferiorly, then 9th, 10th, 11th will be involved. So according to the size of tumor, if the tumor is like 2.5, it may involve CPA, and if the tumor is like 4 centimeters like that, it may impinge on the 5th nerve, and if it is 4 centimeters or greater, it may directly impinge the 5th, and it has effects on the other nerves, and whole cerebellum it can affect. And you will see vertigo, tinnitus has main features, and difficult to understand the speech. So and unable to speak to relevant speech. Okay, that's it. And these diagrams you need to put in this where that, and cerebellar involvement you will test. That's it today, acoustic neuroma. Thank you guys.